Dr. Kaufman is going to come again and speak about non-surgical treatment for lower back pain, focusing on interventional procedures.
So we really need to think about fitting the treatment to the needs of the patient, not the patient to the limits of your treatment. As Dr. Weinstein mentioned earlier, if you're a hammer, everything looks like a nail. And we really need to think about the pros and cons of each treatment and tailor them to each patient specifically. So I'm not going to go through the whole anatomy, but when we think about back pain, as Dr. Hillard alluded to, there are different pain generators. So the disc, could be the facet joints, ligaments, nerve, muscle, fractures, SI joint. So just doing an injection in one of those locations may not be sufficient if they have pain coming from a different location. So let's talk a little bit about the pathophysiology of nerve root injury. So we know that compressing the nerve roots can cause increased permeability of the capillaries. Can cause edema, increased fluid, increased pressure, which then can decrease nutritional support, can produce structural changes on the microscopic level, and edema can precipitate fibrosis as well. Deoxygenation can produce conduction changes, and then chronic compression can cause mechanosensitivity and impulse generation that is ectopic and not caused by specific stimuli. So we do know that inflamed nerve roots are really sensitive to minor manipulation, whereas uninflamed nerve roots are not. So when we inject even just saline into the sheath around a nerve root, those that are symptomatic are painful. Patients that are asymptomatic, it's not usually painful. So that's a way to differentiate. We know that there are many different inflammatory mediators, cytokines, prostaglandins, substance P, macrophages. There's not just one. So let's talk about what the role of anesthetic agents in these injections are. Well, in and of themselves, they can actually have anti-inflammatory effects by inhibiting cytokines and fibroblast proliferation. And there have been a couple studies which have shown that local anesthetics alone on occasion can actually produce long-term pain relief. So here's a list of some of the corticosteroid effects. I'm not going to go through all of them, but as you can see, there's a whole slew of effects that the corticosteroids can have, including blocking the passage of immune complexes. It can cause a reversible local anesthetic effect. So there are a lot of different ways that the corticosteroids work. So why do they work? Why should we do them? Some of the proposed mechanisms are that they have an anti-inflammatory effect, an anti-nociception effect. They suppress immune responses, mechanical debridement. They can stop the pain spasm cycle. Maybe they're just a placebo. So what steroid agents do we use? Methylprednisolone, triamcinolone, betamethasone, dexamethasone. Some are used for different purposes. Some providers have a preference based upon the location of the injection, based upon their anecdotal evidence from their own practice. So you'll see different steroids listed. Contraindications to them. So first of all, patients with a severe or a true allergy to the agents, we especially see this with contrast and lidocaine. And I would say to you there's probably a difference between the patient that maybe has a little bit of a rash, and obviously if they have an anaphylactic reaction to contrast, that would be a definite contraindication. Local or systemic infection, malignancy, coagulopathy or patients on anticoagulants, warfarin, Plavix, pregnancy because we're using an x-ray machine and also the agents can be teratogenic, and then patients unwilling or unable to consent. And we do go through an informed consent process prior to doing any procedure. And I think that patients generally are able to understand, but there are those few patients who I think are not able to repeat back the pros and cons, the benefits, the risks, and they probably shouldn't undergo the procedure. Relative contraindications, hyperglycemia, so uncontrolled diabetes. There have been some studies that have shown that even the epidural steroid injection can cause a transient hyperglycemia. If somebody has really uncontrolled diabetes, it may not be advised to perform the injection until they have their diabetes better managed. CHF, adrenal suppression, or altered epidural anatomy. So what can happen? What are some of the complications? By far, vasovagal response, people passing out, is the most common. Sometimes people have allergic and anaphylactic reactions. Using the X-ray machine, there should not be direct nerve root or cord trauma. Again, I said using the X-ray machine, there should not be. Practitioners who do these injections blind don't know where the tip of the needle is, I would argue, and there probably is an increased risk of direct nerve root or cord trauma. There could be compression by a hematoma or an abscess post-injection. And then sometimes we see transient non-positional headaches, increased back pain, facial flushing, and we talked about increased blood sugar. So what is the epidural space? Where are we putting the needle? So the epidural space is the potential space between the dura and the spinal canal. It runs from the foramen magnum all the way down to the sacral hiatus. Usually it's made up of fat. There are also veins, arteries, nerves in there. And it's widest posteriorly midline, and then it narrows as you go out. So just quickly looking at the nerve root anatomy. So this is where the nerve root comes out, and this is the foramen right here. So anteriorly, you have the vertebral body and the disc bordering it. Superiorly and inferiorly are the pedicles of the adjacent vertebrae. And then posteriorly is the facet joint. And this is just a picture of a C-arm. Some people always ask me, well, what does the X-ray machine look like? And so this is it. It's in the shape of a C, so it can go around the table. It can turn and move, so we can get different views. So how do we get into the epidural space? Well, there are 3 different routes to get into the epidural space: caudal, translaminar or interlaminar, and transforaminal. And again, we talked about doing them blind versus with X-ray guidance. My recommendation is always to do them with X-ray guidance. I think there are very few people these days that do them blind, but there are still some. So let's talk quickly about the caudal approach. So where do you go here? So you're entering through the sacral hiatus, which is the hole right here in the back of the sacrum. And then you are extending the needle cephalad towards the head. So you know that the dural sac, as Dr. Hillard said, ends at S2, so you don't want to thread the needle any higher than that, because you don't want to puncture the dura. It's thought to be the least technically demanding, but more volume of solution is needed to be injected. And the studies have shown that without X-ray guidance, only about 60% get in, 40% miss. So let's quickly look at what this looks like with the fluoro images. So this is the caudal area, cephalad here, and you can see this is a lateral view. This is the sacral hiatus right here, and you can see the needle tip coming up and into the sacral hiatus. So looking at this laterally from a different view, the needle will be coming up through here. What you can see, what this picture is showing you is on the AP, you have the needle coming up here, and contrast dye was injected. So you can see where the contrast is going to make sure that you're not injecting into a vessel, and you can see that it's in the right space before you put the medication in. And same thing over here from the lateral view, you have the needle going in, and then the contrast going cephalad. So interlaminar approach. It's thought to require the most technical expertise, but it allows for the administration of medication to the higher lumbar levels. It has the highest rate of dural puncture, which again is bad. We don't want to puncture the dura. And without fluoroscopic guidance, only about 70% seem to get in, about 30% miss rate. So this is the spinous process, transverse processes over here. The needle is going in this direction. Okay, so this is the disc right here. So what you're seeing here is the needle is right here. You can see the tip of the needle right here, and then the contrast dye extending cephalad and caudally as well. And just a couple other views. So this is an AP view. You have the tip of the needle here that's in the interlaminar space. And then over here from the lateral view, so this is anterior, this is posterior, so you have the spinous processes, you have the vertebral bodies, and you can see the needle tip going in right there. So transforaminal is probably the approach that most of us use the most. The medication is placed at the interface of disc herniation and the ventral dura, and it's generally pretty safe. It's pretty rare to have a dural puncture with the transforaminal. It's done correctly with fluoroscopic guidance. the oblique view is important because this is the view that we'll start with for the transforaminal, looking at the pedicle and aiming underneath the pedicle in oblique view first of all. And the importance of this is using the safe triangle. So using the area where we're not hitting the exiting spinal nerve as we're entering the space. So what we see with this is the AP, so that you can see the needle tips here. And when we inject the contrast, it traces right along the path of the nerve, and it's actually really a pretty pattern. And you can see all three of them just tracing right along there. So when the contrast dye goes in, we know where the medication will be as well. I know that this isn't an epidural injection, but just to show you what a facet injection is. So if this is the facet joint back here, the goal of the facet injection is to get into the capsule, the articular capsule that's around the facet joint. The facet joint runs right here, and you can see the tip of the needle right in the facet joint. And then, just for completion, I put in a picture of an SI joint injection as well. So you can see that you can visualize the SI joint and insert the needle right into it. So questions. Who should have an epidural steroid injection? What approach do you do? Should you use fluoroscopy? How many do you do? What should you put in it? What kind of steroid do you want to use? Is the injection more prognostic? Is it more diagnostic? Is it more therapeutic? And who should be doing these? What kind of training do people need before performing these? And I'm not sure I have all the greatest answers, but let's talk about one question. How many injections should we do? So historically, in the past, patients might have had 3 injections done 1 week, 2 weeks apart, no matter how they responded to the first one, no matter how they responded to the second one. And my recommendation would be that 3 injections should not be done routinely. So I think that's really important to evaluate a patient after each injection. Wait 2 weeks after each, as there is suppression of the hypothalamic pituitary axis, and it can also take up to a couple weeks for the steroid to reach its maximal effect. I would argue that if you do 3, 4, 5 injections and they haven't worked, probably the 6th one, repeating it, is not going to be the effective treatment. Probably after the first couple, you need to revisit things. If the first one works, why do a second one? If the first one works partially, maybe you repeat it, maybe you do it at a different level. But I think that after each one, it should be reevaluated. So in conclusion, I think that injections need to be used. I think they do have a role, both diagnostic and therapeutically, in radicular pain and low back pain. But again, they shouldn't be the sole treatment, and we need to reevaluate after each injection to make sure that performing another one is actually indicated. But we definitely need some more research to answer some of the questions. Thanks.
Okay, let me invite Dr. Lee back to talk about emerging technologies in spine surgery.
This is actually a very exciting time for spine surgeons. We are currently researching and developing a lot of different new approaches to the spine, a lot of new different philosophies to the spine. So what's new? Well, there's a lot of things that are new. Minimally invasive spine approaches, which Dr. Hillard is going to speak more about in detail, but that's definitely a new development within the spine technology or approaches to the spine. A lot of research has also been devoted towards biologics, developing proteins that will help us either A, enhance the fusion, or B, help us slow down or reverse disc degeneration. This is still in its early phase and it's not yet clinically applicable, but personally I believe that's where the future of our technology is. And a lot of technology is devoted towards motion preservation. When you look at the spine, I like to think of the spine as a tricycle. It's really a 3-joint complex. You have your disc space here, and then you have your 2 smaller joints called facets in the back here. So every motion really has 3 separate joints, and it's kind of important to think about when we're thinking about motion preservation. In terms of strategies for motion preservation, some people are performing nucleus replacements, where we replace part of the disc, facet replacement, which are these joints at the back, posterior motion preservation or protection. This is where we place pedicle screws and flexible rods in the back, and this helps us protect spinal motion from degeneration. And what I'm going to talk about today primarily is disc replacement, lumbar and cervical disc replacement. And I'd like to keep them separate because I think they're 2 slightly different entities. Now, in the spine, we have a lot of joints, but we haven't taken this approach to the spine until very recently. This is an example of spine fusion. The question is, can we go from doing this, which is a spine fusion, to this, where we're actually placing implants which preserve motion? Just a little definition of what this is. These are pedicle screws going from the back into the pedicle into the body, and they're connected by a rigid bar here, giving us a rigid construct here. And what you can see here, these are actually inner body cages. You can't see them very well, but they have these little radiopaque markers which define the borders. So this allows us to achieve a fusion anteriorly as well as posteriorly. These are disc replacements here which actually have motion, which I'll demonstrate later. One good indication to fuse a spine is instability. If a patient develops degenerative disc disease or degenerative joint disease to the point where their joints no longer function properly, where they have pathological motion, we know that the bones are supposed to angulate, but they're not supposed to slide or translate on each other like they have here. Well, that's in this presence of failed non-operative treatment, this would be an indication for a fusion. We know that we fuse the spine for deformity. We don't fuse the spine for all deformity. We try to identify the deformity that is likely to progress and be problematic later on in life, particularly in kids. Just for clarification, when we fuse the spine, we have the ability to correct the spinal curvature to the point where we feel it's a stable curve. But we don't have the ability to correct the curve and maintain motion. So the overall strategy is to correct the curve and fuse it in that position. There are some other indications for spine fusion, but I want to jump to this one. This is degenerative disc disease or discogenic pain or black disc disease. I made this in a slightly smaller font because this is more of a controversial indication for fusion. The classic history for someone with discogenic pain is they have back pain, which is worse with flexion. These people will often be standing up because they can't tolerate sitting. On an MRI, they'll have abnormal findings at the L4-5 disc, degenerative disc here. And in this patient, you can see we have healthy discs at the other levels here. Here we have an example of a back pain or discogenic pain, and a patient has one single abnormal MRI finding. This must be the pain generator. Some surgeons would perform a fusion at this level, eliminate the motion, and theoretically eliminate the pain. Other surgeons would choose not to do that. This is a problem that we don't clearly understand the etiology of this pain, and we don't understand how to treat this very well as well. So this is really a controversial indication for spine fusion. What are some of the advantages of disc replacement over fusion? Well, the advantages are, some of them are obvious. Well, disc replacement, you maintain motion, so you're going to have less stiffness. In a fusion, well, we have to obtain a fusion, and we don't obtain a fusion at the time of the surgery. It takes about 6 weeks to 6 months to really fully achieve a fusion. With a disc replacement, theoretically, we can mobilize a patient, get him back moving sooner, get him back to work sooner. And finally, a big theoretical advantage of disc replacement over fusion is the less stress in the adjacent segments. And I'll talk about this in a little bit more, but you can imagine with fusing any joint, the joint above and the joint below are going to be exposed to higher and altered biomechanical stresses. With some of the disadvantages of a lumbar disc replacement, well, you need an anterior approach. Now, this isn't particularly complex. It's an incision through in the abdomen. To gain access to the retroperitoneal space, we have to sweep the peritoneal contents to the side, work around the great vessels. There are some risks. In men, there's about a 1% risk of retrograde ejaculation. So if it's a young male who hasn't had children yet, that is something to consider. And also, this disc replacement, as you can see by its position, there's a lot of important structures around this metal that we put into the body. There's a spinal canal posteriorly, there's great vessels anteriorly, there's the abdomen right there, so there's also potential for catastrophic failure. And any dislodgement or displacement of any of this metal or plastic is bound to make any surgeon a little bit uneasy. So if you imagine any joint that's fused, if we fused your knee, if your knee was locked in extension, and you had to walk the rest of the day with your knee locked in extension, you could probably do it, you could probably get around, you probably couldn't run, but by the end of the day, your hip and ankle might be a little bit sore because they're kind of taking the stress of most of that walking. Well, the same thing happens in the spine. I mean, these are all several different levels of joints. This is an example of someone who's had an L5-S1 fusion, and 5 years later, she developed a spondylolisthesis here at the L4-5 level. We can see the step off here. And she became symptomatic from it, had subsequent stenosis, and had to have her fusion extended one level above. According to recent reports, the rate of reoperation is about 36% per 10-year time period. What does that mean? It means if you have a successful lumbar fusion, and this is a successful procedure, the odds of you having a surgery at an adjacent level are about 36% over a 10-year period. And that is not insignificant. Let's examine the role of total disc replacement and compare it to a fusion. For lumbar deformity, or for deformity in general, we know that fusion isn't a viable option for deformity. Is this a scenario where we would do a disc replacement? Well, obviously not. The pathology clearly extends over many different levels, and it would be unfeasible to put a disc replacement in many different levels. So this is not an indication. Deformity is not an indication for disc replacement. Well, what about instability? Well, you can make an argument for this. Clearly the disc is degenerated here, so a disc replacement would theoretically restore this disc space, and if we just push this L4 back on L5, maybe that might work. But it's important to remember that it's important to think of the spinal motion segment as a tricycle. You got the big wheel here, but then you also have two small wheels back here, and with this amount of slippage, these two facets back here are bound to have some destruction and degeneration. So if all three wheels of the tricycle are damaged and you replace one wheel, you're not going to get that tricycle moving again. You have to replace all three or find another option. So this is not an indication for disc replacement. What about degenerative disc disease? Here's your MRI with our L4-5 degenerative disc disease. As I spoke before, this is really a controversial indication for fusion, for surgery in itself. But this is the primary indication for a disc replacement. The degenerative, bulging, possibly minor herniated disc is an indication for a disc replacement surgery. So you can see that the indications for lumbar disc replacement are somewhat controversial to have surgery in the first place. So what are the results of lumbar disc replacement as a whole? Well, the long-term data is still pending. We don't know much about the adjacent segment disease or degeneration yet. The jury's still out on lumbar disc replacement. There are some FDA-approved models of lumbar disc replacement, and we're still waiting for more data. Now, cervical disc replacement is a slightly different animal. Here we have a cervical fusion with a bone graft in between and with a plate on top. And here we have a picture of 3 cervical disc replacements. Now, what are the advantages of a cervical disc replacement? Well, again, you maintain motion, there's less stiffness, there's no need to fuse, and we can potentially mobilize these patients sooner, and there's a theoretical decreased adjacent segment disease. What are the disadvantages? Well, we have to worry about implant instability. Again, like the lumbar spine, there's a lot of important structures around this disc replacement in the neck. Questions about cost effectiveness compared to the gold standard, and the questions of superiority to the gold standard. The gold standard for someone with this condition would be an ACDF, which is an anterior cervical discectomy and fusion. Again, just like the lumbar spine, adjacent segment degeneration does occur in the cervical spine at a rate of about 2.9% a year or 25% over 10 years in an often quoted study. Again, this means if you have a successful fusion in your cervical spine, the chance of you needing an operation at a level above or below is roughly 25% over the next 10-year period. And that is not insignificant. So what are some of the indications for fusing the cervical spine? Well, like the lumbar spine, instability is an indication for fusing in the presence of failed non-operative treatment. Like the lumbar spine, this is not an indication for disc replacement because while the disc may be degenerated, we have these facets back here, and if we don't address those facets, there's no point in replacing one of the 3 joint complexes at that motion segment. Again, deformity, like the lumbar spine, fusion is a viable option for deformity in certain situations, whereas disc replacement is not. What about herniated disc? We often hear about herniated discs in the cervical spine. This is an MRI where we can see this patient has a herniated disc at 5'6", which is pushing back into the spinal canal against the cord. You can see the outline of this herniated disc right here pushing into the cord and impinging on this exiting nerve root. So a fusion procedure is indicated for this condition, and a total disc replacement is indicated for this condition as well. So the gold standard is the ACDF, anterior cervical discectomy and fusion. And essentially what we do is we make an anterior approach. This is anterior and this is posterior. We make an anterior approach to the cervical spine. We resect this disc tissue out here, take all the offending disc so it's not compressing the spinal cord or any nerve roots. We then plug up, now we have an open space where we took out our disc. We place the bone graft into this space and cross it with a plate. It's already been done at this level C3, C4. So essentially we have a fused segment here. This whole segment here is now one mobile segment or one non-mobile segment in itself. So that's an ACDF, and this is an extremely successful procedure. This is an outstanding procedure with success rates between 90 to 95%. And it's really hard to imagine that anything else could beat this procedure in terms of effectiveness of reducing a radiculopathy or myelopathy. The total disc replacement procedure is very similar to this procedure in that it uses the same approach. It's the anterior approach to the cervical spine. Again, we take all the disc material out, take all the compressive areas off the neural tissue, but instead of putting a bone graft on a plate, we place a disc replacement here. And the purpose of this disc replacement is to maintain motion and also to protect the motion of other levels. You can see in these dynamic films here, we do maintain motion with a flexion, extension, and side-to-side bending. It's important to remember there's not a whole lot of motion on each individual segment, probably about 6 to 7 degrees. At the Cervical Spine Research Society this year, the first 4 papers are about total disc replacement versus fusion in a prospective study. And all 4 of these papers seem to suggest that disc replacement is at least comparable to a fusion, And some studies even went as far as to suggest that disc replacement has superior clinical results compared to fusion. Again, these are short-term studies. The preliminary data thus far suggests that there's a lower incidence of adjacent segment degeneration, so that these disc replacements are actually doing their job. To summarize, total disc replacement, lumbar and cervical, are slightly two different animals, and the real big difference is the indication to do these procedures. In the lumbar spine, the indications to do surgery in these patients is somewhat controversial across all spine surgeons. And in the cervical spine, the indication is actually based on a pretty solid foundation. A single-level herniated disc is a solid foundation or a solid indication to perform procedure in the presence of failed non-operative treatment. For both of these, we do need long-term follow-up. It's pretty exciting to see how this will develop. My personal feeling is that I think the cervical disc replacements will be seen more frequently in the future, and I think the jury's still out on the lumbar disc replacement. We'll just have to wait and see. And that's all I have to say.
So now Dr. Hillard will come back and speak about minimally invasive surgery of the spine.
I just want to touch base on sort of the history of minimally invasive surgery and then go into more details about the things that we can do here at the UW. Lumbar percutaneous endoscopy is something I've done in the past. I'm not currently doing that in the UW. I mainly do lumbar microendoscopic discectomy. And there's a difference in those two, and once I show the different techniques, you'll see what they are. And then lumbar decompressive laminotomies for stenosis can be also done minimally invasive. Lumbar fusions can be done minimally invasive. And interspinous decompression devices can be used for decompression of lumbar stenosis, which is probably the most minimally invasive. Classically, the way we treat lumbar stenosis, I've shown those pictures of the bony elements narrowing the spinal canal, is an open laminectomy and decompression. So you would make this large midline incision, and once you get the midline incision down, you would pull the muscles aside in order to expose the bone. And once you get to the bone, then you can sort of decompress and unlift or unroof the spinal canal and make room for the thecal sac and the nerve root as well. And there's two types. One, you can actually drill off and take off the entire lamina on both sides with the spinous process in the middle. And therefore, if you think about it, all the elements and all the ligaments that attaches your muscles to the bony structures are all removed. So then the muscles are just going to fall back together. Another technique is to sort of leave part of that sort of interspinous ligament and do sort of what we call laminotomies. And that's another possibility. But they still require open techniques for us to expose the bone entirely. Here's a pretty gruesome picture of what we can do and what, sometimes we still do. And this is sort of the midline incision. You've got the muscles pull aside. You have these big retractor blades pulling the muscle aside just so we can get to the bony element. This is the spinous process. These are the lamina, and here laminectomy has been performed. And in this case, it was an indication for fusion. I believe it was a fracture with a piece of bone in the canal that required decompression and fusion. So open laminectomy for stenosis, well, it works. It helps a lot of patients. Certainly, you can achieve very good results, up to 85% in terms of decompression. There are studies that have shown that. When you do a decompression for lumbar stenosis, you have a chance of having some troubles later down in the year. You can have restenosis. About 10 to 20% will require some type of reoperation. But still, overall, I think there is success in terms of open surgery for lumbar stenosis and decompression. And the patients were the ones I've spoken to you about where they just can't walk, not even a block. They have better quality of life once they're decompressed, and they'll be able to use their leg and walk without much problem. So when open surgery works, why develop minimally invasive? Well, we can always be better at what we do, and that's sort of a goal of any sort of, I would say, physician practicing and taking care of patient. There's the idea that this minimal destruction of natural tissue plane could help patients in terms of recovery, help them in terms of stability. So overall, hopefully, develop a minimally invasive technique that will decrease the pain level, decrease the medication they require, maybe even less time in the hospital, less blood loss, of course, if you're not cutting a big opening, and perhaps faster return to work. And also there's this little idea that it cosmetically is a little bit more pleasing. That's important to some patients. And so the history of minimally invasive spine surgery. It started off with chemonucleolysis, and actually I'm glad I follow suit with two great speakers because you've already done the work for me. So a chemonucleolysis entails sort of the same technique that you get into the disc space. And in that procedure, you inject something, one common agent is chymopapine. It's an agent that seems to affect sort of the macromolecules in the disc space and somehow help sort of dehydrate the disc and therefore perhaps shrink the disc. So that's been done. There's some good results. Structurally, how much shrinkage can you get? So I think that's the thing. If somebody has severe stenosis, not just a disc problem, they probably may not be helped with that. In terms of what other minimally invasive surgeries are available, there's the percutaneous discectomy that uses a laser. A lot of people love the term laser. Spinal endoscopy can be done. You can do video-assisted thoracoscopic surgery. In the past, when you do thoracoscopic disc, you have to do a pretty big whack and split the rib open, but here you can actually put some ports in there and do the surgery that way. You can do laparoscopic lumbar surgery, minimally invasive microendoscopic discectomy, and lumbar fusions can also be achieved with a minimally invasive technique. So the techniques that I will talk about specifically and go through some cases, that is percutaneous endoscopic discectomy, lumbar microendoscopic discectomy, fusions, vertebroplasty and kyphoplasty, and then this interspinous decompression device. So we'll start off with a case. You have a 45-year-old woman, history of lumbar disc problem, a left L5S1. She's had surgical treatment, resolution of her pain. But then, unfortunately, 6 months later, she began to have, again, this atraumatic, radiating pain down the right lower extremity. Starts in the low back, goes over to the dorsum of the foot and the region of the big toe. So that sounds like L5. And that's, she also has a little bit of mild extensor hallucis longus. And that's also L5 as well. And just basic history and examination, motor function, she did have a slight weakness of her EHL, and sensory decrease right over to the dorsum of the foot to fine touch as well as pinprick. And this is her MRI. And you can see here, this is the sacrum. First, this is L5S1, this is L5, so here's L4-5. So I expected she had an L5 pathology, which usually comes from the L4-5 disc. On the axial, you can see that there's this disc coming off to the right side. Here's the L5 root, and there's where it can be compressing the foramen. And so what are the treatment options for something like this? Well, the stand is to go in from one side, pull the muscle aside, get to the lamina, open up the lamina, and then get to the disc and do the discectomy. You can even consider a fusion in somebody who's had a previous operation. And then there's this endoscopic partial discectomy that can be done. And in this case, we decided to do this endoscopically with the laser technique, but mainly the endoscopic sort of percutaneous component of the surgery. So in this case, as Dr. Kaufman had pointed to, how do you do an injection? You actually try to get into that triangular safe zone, and there's sort of just some markings to come off lateral in order for us to do our procedure. The patient is prone. We use fluoroscope. We kind of mark the levels that we need to be. And then we come in on the side with a spinal needle, getting into the disc space. This could be sort of where the disc herniation is. And on this model, you can see there's that triangular safe zone where you can enter a needle without injuring the nerve root. Here's a spinous process facet joint. Here's sort of where the midline would be. And this technique was sort of promoted by Dr. Young, who has done many, many cases this way. And so in this particular patient, we, with AP and lateral x-ray, we were able to get the needle down to the L4-5 level. And once we're in that sort of triangular zone, that's exactly where on the MRI I showed you, that's where the disc herniation is. And so with the needle in position, then we do an injection in order to make sure that we're in the disc space there. Also make sure that there is some type of fissure, some type of tear, and that the disc is still existent. Once we get that into position, we start using these dilators. Small, they're tiny, tiny, and this is much more, this is smaller than sort of the more routine cases that I'll show you later that I do. So you put some dilator in, and then you put this device, which actually has a little sort of a sharp edge that allows you to cut the annulus. And once you enter in the annulus, and you put a little scope in there, and through the scope, basically you start to peel away pieces of the disc, and hopefully with making room and coring out discs within the annulus, you can perhaps pull in this fragment there and then take that out. And it's all a 2D image endoscope. And when patients ask you, well, can you do this laser? There is some YAG lasers that you can actually put through these tube retractors and also sort of use it to sort of burn and shrink the disc. But mainly the mainstay is this little pituitary that allows you to pull the disc out. So in this case, this is what we did in this lady. This is our cannula. And this is sort of an in-drop picture that I try to take off the screen. Here's sort of the nerve root, and this is sort of the epidural space. And that's where we work. And she did well. I mean, it's very few cases of these that I've done. But in somebody who's had more experience, such as Dr. Young, he's done quite a number of cases, over 300. At many different levels. Again, you can see that most disc herniations are at L5S1 and L4-5. And with decent results in terms of performance assessment, worker injury, and also in terms of complications, pretty reasonable in terms of his complication rate. So in his case series, he showed that he's probably one of few who's been doing a lot of these. Lumbar endoscopic discectomy is possible viable as compared to sort of the open discectomy. It's good for the intracanal and foraminal and extraforaminal location of disc herniation. And because it's such a small little incision, just sort of a little K-wire and dilator, patients can go home that same day or the next day. So that's something that I've done in the past, but I've kind of ventured down this other route, which is more common for most surgeons across the country to do. And this is called the microendoscopic discectomy. And the reason for this microendoscopic discectomy is because as surgeons, we usually don't come in on the side like the rehab physician is to do the discogram. So it's actually not as familiar territory. So the familiar territory is still sort of the midline approach here, where usually all the muscles sit out here, and you come in, you drill the bone, and you get to the disc. So how do we do that minimally invasive, but yet stick with what we know and what we're used to in terms of what we see in anatomy? And so one way to do that is, instead of making our midline incision and pulling all the muscles aside, you can actually make just a small incision, take some dilators, and put a little tube right over the area where we need to work. And through that tube, put a little camera in there. And through the visualization of the camera, you can still drill off the bony elements to get access to the disc, and then do our discectomy that way. And so this is called the microendoscopic decompression. And with decompression, using that technique, you can actually decompress somebody by taking down their bony elements for lumbar stenosis, not just a discectomy, but stenosis. In the case of lumbar stenosis, here's sort of the classic where you pull the muscles aside. So in terms of the microendoscopic technique, you would actually just dock the tube retractor right over the bone. You would drill off the bony elements on this side, and then you would just angle it to the opposite side. And using the camera, you can drill the bone on the other side, and therefore basically take off all the bone in the back, and again, unroofing the canal and decompressing the patient and giving them symptomatic relief. Here's what it would look like. Tiny little incision. It's an 18 millimeter port, so the incision is about 22 millimeter. And this is an example of the connection. You have the C-arm here. You have the small incision. The tube retractor is in position. It's held in, to the bed. And this is sort of where the camera sits as we're working. And visualization is very similar to sort of that open picture I showed you. Here's the fecal sac, and we're taking down the ligaments, and the picture is the same. It's the same as what we would do open, except now it's just through a tube, a little smaller. And so it's at least very familiar territory, but the idea is that you traumatize the muscle less. So what are the results of something like this? Well, Foley and Dr. Fessler are two well-known neurosurgeons who has developed this technique. And in their case series, they had 150 patients. What they shown, and this is sort of a preliminary study, was that the mean operative time was about 97 minutes, which is still a little longer than sort of the open procedure. I was actually interested to see that their hospital stay was a little long, so that I'm not sure I can explain that. But their mean return to work was pretty reasonable, 17 days. And I think maybe the base of this sort of earlier study was to show that complications weren't as great as people would think. And so they did have some dural tears, they had some delayed dural tears, and they had a wound infection. And these numbers are actually pretty comparable. And what they showed in their study is that usually there is a steep learning curve. Their first 30 patients versus their last 30 patients had quite a difference in terms of blood loss and the dural tears and everything. It was much, much less in the later curve. So once you get through that learning period, you can have very good results. Here's a case that I pull off in terms of PubMed, and a much, much larger series, but it came out of China, I think. But it was published in Spine 2006. 873 microendoscopic cases versus open cases. And in this study, they were able to demonstrate that in terms of pain improvement, there was no difference, but in terms of return to work, it was much better. Hospital length of stay was shorter, and also estimated blood loss was much less. So basically, it shows that, certainly the improvement is significant, is the same in terms of neurologic improvement to open surgery, and yet perhaps there is sort of less in terms of time in the hospital and also return to work. And again, they also agreed that they still have a bit of a learning curve too to get over before they got their best results. This is a study focused, so those two studies were on discectomies, minimally invasive technique. And this study is focused on decompression for lumbar stenosis. And this is by Ku and Fessler. They looked at 25 patients compared to the second group of patients of 25 who was treated with open decompressive laminectomy. And basically, the patient who underwent the minimally invasive procedure had good resolution of their pain, improvement of their symptoms. So overall, you add these two together, it's pretty good. But 16% remain unchanged. But basically, they showed that in terms of achievement of neurologic impingement, they were able to achieve the same as the open procedure. At the UW, we've done more than 58 cases, but these are sort of our preliminary results for our microendoscopic decompression for stenosis with an 18-month follow-up. Average age, 59.7. Some patients present with leg pain or claudication. These are the different levels that we treated. Some patient had synovial cysts. And basically in the 58 patients in the preliminary studies, 56 out of 58 had very good relief of their predominant symptoms. 56 out of 58 were discharged within 24 hours. And then one discharged at 48 and another discharge at 72. In terms of complications, the other people have reported complication rates with these techniques. 5.3% dural tear, perhaps some facet fracture, and those are all, again, most of it is probably in the beginning of their learning curve in terms of the technique itself. They did have a little bit, I thought, a little higher in terms of transient neurologic complication, which I'm not sure I agree with, but to mention it since it is published data. In terms of our complication, we had not too many, but in the beginning there was a couple of CSF leak or dural tear. One patient needed a reoperation at 3 months because their symptoms recurred, and one at a year because they probably had multiple disc problems and needed a fusion at that particular level. So we talked about now just the decompression, open versus minimal invasive. And now, can you do fusion, which is a bigger operation, through a minimal invasive approach? And the answer is yes, we can. In terms of fusion and how well it works for patient, again, it's selection of patient. But in sort of this all-comers that Lewis and Nazarin looked at 350 patients, they did decompression alone versus decompression with fusion, and they actually had good results with patients, probably those select fews who did the decompression and the fusion. Key point is patient selection. Again, here's a patient that I would consider fusing because there's not just lumbar stenosis, but also a spondylolisthesis component of the problem. And so in this particular patient, here's her flexion extension x-rays. Showing the bone moving back and forth. And an open procedure was done. This is sort of one of my earlier cases that I decided to do open. Pedicle screws connecting the L4 and L5 bone and a bone graft in between. And so open laminectomy fusion with instrumentation overall has very decent results. Here's a study who was an award winner, 67 patients with 2-year follow-up. They achieved excellent results and good results in 76% with the decompression of fusion. They were able to achieve fusion in 82% of the case. And overall success rate, overall fusion rate didn't influence the patient's outcome. In conclusion, this single level fusion for degenerative spinal listhesis can have pretty decent results, about 76 to 80%, which is better than sort of the 50-50 that I quote patients for fusion for low back pain sometimes. Can you do this minimally invasive? Well, this is a case where we did do this minimally invasive. This is a 70-year-old woman with neurogenic claudication, bilateral leg pain. She has this grade 2 spinal listhesis and this lumbar stenosis, and she was quite symptomatic from her lumbar stenosis. Ways to do a minimally invasive fusion. Certainly the important thing is a decompression. I already showed you with those little tubes. You can go down there and do all the bony decompression. And then so now how do we put these screws in percutaneously or with minimally invasive technique? So I have no disclosure in terms of any of the pictures that you might see that are part of companies. But this is one technique where it's actually, you can put screws in just with little stab wound incisions, and then the screws have to be connected to the rod like Dr. Lee showed you. In the open procedure, we lay the rod in, but in this particular procedure, you can actually, there's a machine that allows you to sort of, in an arc, put the rod through so you can connect the two screws together. And so therefore, you have just a tiniest little skin incision. There's a tube, screws and rod put together. And so this is something you can do. In this particular case, actually, what we did was we call it, it's still minimally invasive, but it's mini open. Instead of moving and pulling the muscles aside, you just make small incision in the side, and you actually just, again, dilate to the area where you need to do your operation. And so minimal lumbar fusion, the advantages are that you can achieve neurologic decompression. You can also achieve fusion. And overall, technically, there should be less pain, and also cosmetically, it should be better as well. The complications, however, of these lumbar fusions are that fusion is better if you have a lot of surface areas for you to lay the bone graft on so you can have the bone grow between the two vertebrae. And so there's a little less surface fusion you're working with. But then again, we mainly do a lot of interbody graft where we actually core out the disc space and put bone graft in there. So that sort of compensates for the fact that we didn't pull all the muscles aside and just looked at naked bone as we do our operation. And with the fusion, when we work through the tube, we are using an endoscope, which is a two-dimensional picture, which can be a little more difficult. And of course, with working through a small hold, you can get some dural tear and some CSF leak. One way to get around sort of this two-dimensional picture is actually, instead of using the endoscope, some people actually bring the microscope in, and then you have a 3D view. And that can sort of put you back in sort of the safety zone where you know what you're looking at with three-dimensional. In terms of fusion results with minimal invasive, Schwender and Foley looked at 49 patients with an 18-month follow-up. And these were their indications. A lot of it was the spondylolisthesis, which we know have better results. Their operative time is still pretty long. This is about 4 hours for a minimal invasive. It probably can be longer. And open surgery for one level, you could probably do about 2-3 hours. The estimated blood loss is certainly a lot less. Probably at open surgery, you're at least 350 for one level, maybe a little bit more. Hospital stay, this is something that I believe in. I'm not sure, those papers were published, but I really thought those hospital stay lengths were very long. But this is comparable. 1.9 days in the hospital for a minimally invasive fusion is great compared to sort of the open, which takes probably at least 2-3 days, maybe a little longer. And in all their patients, they had good, if they had radiculopathy pre-op, they all had improvement post-op. They did have some complications, as it is with any newer techniques. 2 instances where the screws weren't in good position. They were able to achieve discontinuation of their narcotic use. Their visual analog scale did decrease from a 7.2 to a 2.1, and their Oswestry disability index also decreased from 46 to 14. And also at the time of surgery, they felt that they were able to achieve fusion based on radiographic findings. This is an interspinous process decompression device for treatment of lumbar stenosis that can be done without general anesthesia under sort of local medication with a little bit of light sedation and also sort of an incision that's pretty small. In particular, the device is called an X-Stop. I have no connection with them, but I have done a fairly number of cases in my fellowship with this technique with very good improvement in terms of patient in terms of their problem. The device itself acts to open up the canal. And so this device is implanted in between the spinous process at the symptomatic disc level. Again, it's under local. It's an outpatient procedure. It takes less than an hour, usually about 20, 30 minutes. The only contraindication is if you're osteoporotic, then those spinous processes will not withstand the force of this device going in between them. So here's an example of an 88-year-old woman. And she has this severe lumbar stenosis. You can see here at 2-3 as well as 3-4. You can see how tight the canal is. Instead of a round space, it's a triangulate space because, again, it's sort of the 3 joints that causes that triangulation. We took it to the OR. We used fluoro. I agree with Dr. Kaufman that you should use fluoro if you can. It only helps. It doesn't hurt. So we take a lateral X-ray. We try to identify the level where we need to be. And then we make our incision. And this device, you start off with a little dilator in between the spinous process, open it up, and then you slip this device in, and it locks into position with a wing, and this is what it looks like. On a lateral view, we actually did both her level, and this is an AP view. So it stays there, and the whole idea is that with the stenosis in mind, stenosis is from disc bulging from the front, because as the height of the discs are plump when you're younger. As you get older, they sag down. So when you sag down like an inner tube, it bulges in. So that narrows the canal in the front. In the back, your ligaments get old too, just like the veins on your hand that start to see sort of this wiggling of the vein across your hand. It's because the collagens and everything stretches with time. So the ligaments in your back stretches. So as you get older, they have no place to go, so they'll bunch up, and they will narrow the canal space from posteriorly. And so what this device does is that you jack up the interspace again, and you put the device there. So therefore, you recreate sort of the space for the canal by perhaps helping sort of decrease the disc bulge in the front. And from the back, you're taunting the ligament, so therefore you have less of that bulky ligament bunching up and causing stenosis. So that's sort of the anatomic theory of why this worked. And there's good results with their first initial 191 patients that Siddiqui looked at. They had a 91 control, 100 x-stop, mean age was 70. They looked at the Zurich claudication questionnaire, and at 2 years, the x-stop patients did improve with 45.4% over their baseline symptoms. And this is compared with the control group, which had no intervention, which is 7.4%. So it actually had some decent results. And again, I would reserve that for the very sick patient. Vertebroplasty and kyphoplasty. We can use this technique to help with some fractures. It could be traumatic fractures, osteoporotic fractures, or even some tumor pathologic fractures, and it really all depends on the case. The kyphoplasty part of this is that in addition to sort of putting the cement in the bone, you actually use a balloon to sort of maybe perhaps restore the fracture or create a space where you can actually put more cement for stability. And so I'll show a case with kyphoplasty that we did. This is a 79-year-old woman with chronic low back pain. She had a laminectomy in the past, seen by other surgeons, but basically her main complaint was sort of this worsening back pain. She's a pretty sick lady, hypercholesterol, has had other surgeries in the past. At first we weren't sure if her fracture was pathologic or was it osteoporotic. Her labs didn't point to any direction. This is what her x-ray looks like. Here's her compression fracture. This is sacrum, L5, 4, 3, 2. So L2 compression fracture. Here's what the CT looks like. You can see that the body is definitely collapsed. And this is the MR. And actually, interestingly enough, we weren't sure if this was pathologic, so we did some contrast study, and it didn't light up. But eventually what we did ask to be done in her case was we had a CT-guided biopsy to make sure it wasn't tumor-related. And so it came back just fibrocollagenous tissue, which is not tumor. And so in her case, with her severe back pain, we decided to see if we can help her with her back pain in terms of doing a vertebroplasty and kyphoplasty. So again, we do double plane fluoro for us to get into the right position. We mark out incision. This is the vertebral body that's involved. These are the pedicles that we will introduce the cement through. That's sort of the safe zone. So we mark our incision where the pedicles would be, and we start just lateral to it. so that we have room for the, sort of the skin and the fat and the muscle tissue before we get down to the pedicle. Then we put our cannula down the pedicle to get into the vertebral body, and the goal is to sort of put cement in that vertebral body. So this is what it looks like, double cannula on both sides. This is what the x-ray looks like with the cannula sitting in position. AP view, lateral view. We go in there, the first thing you do is there's some device for you to sort of break up the fracture and move it around. Then the balloon is placed in so that you can sort of open up the space so you can have room for the cement. And also the idea that perhaps if there are fracture pieces, you can perhaps maybe restore that, the piece back into its original position. Then you do use these tubings that are filled in with the cement that first, there's liquid as you start off, and after a certain period of time, they will harden within the bone. There's double injection through the area here. And you can see we're getting contrast mixed with the cement all around. And basically trying to, achieve stability in that level, because basically, if you have a broken arm, you have a lot of pain because there's micromotion there. That's why you put a splint or a brace or even fixate it. And so a broken bone in the spine can be the same in terms of pain. So when you put the cement in there, the idea is that with the stability, you can actually help with their pain. And actually, interestingly enough, she had immediate relief of her pain. And actually, one reason for that, I think, is with the cement that we use, there's a heat component. And I think with the heat, you actually can sort of burn some of the pain fibers and generators around that level. So she did very well. Last but not least, I want to talk about minimally invasive tumor resection. So we can take tumors out through a tube. Here's a case of a 43-year-old woman with back pain, right leg pain, mainly to the calf and thigh. And interestingly enough, this is what her MRI shows. There's two little lesions sitting behind the body of L3 and the body of L2. And here's the axial. Really takes up a lot of her canal space. And sure, I can do this open, just like that initial procedure I showed you where it's like big, the whole muscles is splayed out, or we can do this through a tube. And so here's an X tube. It's a little bigger than the decompression we use. It's about 24 millimeters in terms of diameter. And so through the tube, we've now pushed all the muscle aside. We've already done our bony drilling. Here I'm looking at the dura itself, the thecal sac. Now we've opened up the dura, and there's the tumor. And here's the tumor coming out. And look, the size of the tumor in the tube is about the same, basically. So we've barely squeezed it out. So it's probably reached the limit of how much we can do through the tube. And she had that smaller tumor here, the little lesion, and we found that. Again, these are the nerve roots, just like you would see in an open operation. And this is what it looks like after everything's gone. And then we can suture it up and close it. So we can do a lot with minimally invasive technique. It has to be the select case and the select patient, of course, the right pathology, but we can certainly achieve good results. And so that's the fun part of what we can do as surgeons. Glad to be here today and glad to be able to present to you guys with Dr. Kaufman and Dr. Lee.